Hello everyone. Welcome to the third lecture in the series of gastrointestinal pathology. In the first two lectures, we discussed the pathologic processes affecting the esophagus and the stomach. In this lecture, we will discuss the non-neoplastic disorders of the small and large intestines. At the end of this lecture, you will be able to list the common congenital disorders of the small and large intestines. You will be able to identify the causes behind intestinal obstruction. You will be able to recognize diverticular diseases and the common vascular disorders and understand their pathophysiology. You will also be able to identify celiac disease and understand its pathophysiology. We will talk briefly about infectious processes, and you will be able to compare and contrast ulcerative colitis and Crohn's disease, which are types of inflammatory bowel disease. This is the outline that we will follow in order to achieve the learning outcomes. First, we will start with the common congenital disorders of the small and large intestines, and these include intestinal atresia, malrotation, omphalocele, gastroschisis, Meckel diverticulum, and Hirschsprung disease. Intestinal atresia is a congenital defect that results in complete obstruction of the lumen. This is a picture for you to know that there are different types of intestinal atresia. You do not need to know these specific types. The intestine, shown in the picture on the left, ends in a blind pouch. This is complete obstruction or atresia. Partial or incomplete obstruction is called stenosis. In duodenal atresia, half of duodenal atresias occur with Down syndrome, although conversely, few cases of Down syndrome have duodenal atresia. In the picture on the right, we can see multiple intestinal atresias. Malrotation is another congenital disorder affecting the intestines. The proper development of the midgut involves a complex process. First, the gut will herniate out of the abdominal cavity during gestation, and then it will rotate 270 degrees counterclockwise around the axis of the superior mesenteric artery. Then the midgut will return to the abdomen around 10 to 12 weeks of gestation. Any abnormality in the above process of rotation and return to the abdomen will result in malrotation. Malrotation can result in duodenal obstruction and midgut volvulus. Midgut volvulus refers to when the intestine twists around the superior mesenteric artery. This will lead to vascular compromise, which is termed midgut volvulus. And if this is not corrected quickly, necrosis will occur. Infants usually present with bilious emesis, secondary to the midgut volvulus. So, bilious emesis in an infant is a medical emergency that needs prompt attention. Omphalocele is another congenital defect. It is a defect of the anterior abdominal wall and occurs at the site of the insertion of the umbilical cord. It occurs when the closure of the abdominal musculature is incomplete. Therefore, the abdominal viscera will herniate out into a membranous sac, and this membranous sac is covered by amnion and peritoneum. Omphalocele is associated with Beckwith-Wiedemann syndrome and other trisomies and structural abnormalities, such as cardiac and genitourinary anomalies. In this picture, we can see an example of omphalocele, where there is a thin membrane covering the herniated abdominal contents, and this omphalocele occurs in the region of the umbilical cord. Gastroschisis is similar to omphalocele. However, there are few differences between them. Gastroschisis is also a defect of the abdominal wall. However, it occurs just to the right of the umbilical cord insertion. So it is more of a lateral defect, whereas omphalocele is a midline abdominal wall defect. In gastroschisis, the abdominal contents also herniate outside of the body. However, they are not covered by a membrane. So gastroschisis is distinguished from omphalocele by the absence of a sac covering the eviscerated contents and by a normal insertion of the umbilical cord, unlike omphalocele. Gastroschisis occurs as an isolated defect. It is not associated with trisomies or structural abnormalities as in omphalocele. In this picture, we can see the herniated abdominal contents and they are not covered by a membrane. Now we come to Meckel diverticulum, which is the most common congenital anomaly of the gastrointestinal tract. It occurs as a result of incomplete obliteration of the vitelline duct or omphalomesenteric duct. The vitelline or omphalomesenteric duct connects the lumen of the developing gut to the yolk sac, and incomplete obliteration of it results in Meckel diverticulum. Meckel diverticulum occurs as an outpouch of the ileum on the anti-mesenteric side. So you will see an outpouch on the side that is opposite to the side where there is the mesentery. And the wall of the Meckel diverticulum is composed of all the layers of the intestinal wall. This is referred to a true diverticulum. This is as opposed to Zenker diverticulum, which is a false diverticulum, and we discussed it in the esophageal lecture, where we said that the Zenker diverticulum occurs as a result of herniation of the mucosa. In Meckel diverticulum, however, it is a true diverticulum, and the wall is composed of all the layers of the intestinal wall. So it includes the mucosa, submucosa, muscularis propria, and serosa. The interesting thing about Meckel diverticulum is that it can contain ectopic mucosa. The most common type of ectopic mucosa that it can contain is the gastric mucosa. It can also contain pancreatic mucosa. Gastric mucosa, the significance of containing gastric mucosa is that it can secrete acid, and this acid can lead to ulceration of the adjacent ileal mucosa, leading to bleeding. The rule of twos has been associated with Meckel diverticulum. It occurs in around 2% of the population, is around 2 inches long or 5 centimeters, and 2 feet away from the ileocecal valve or 60 centimeters. It occurs twice as common in males and is most often symptomatic by the age of 2. The majority, 85 to 95% of patients with Meckel diverticulum are asymptomatic. The most common presentation of a Meckel diverticulum in children is painless rectal bleeding. The bleeding is secondary to peptic ulceration, secondary to secretion of acid from the ectopic gastric mucosa. Other symptoms that may occur include abdominal pain resembling acute appendicitis, intestinal obstruction, and intussusception. Hirschsprung disease is also referred to as congenital aganglionic megacolon, and as the name implies, it is due to failure of the ganglion cells to migrate to the wall of the colon. Ganglion cells are derived from the neural crest cells. Occasionally, Hirschsprung disease is familial. 10% of Hirschsprung disease occur in patients with Down syndrome. The most frequent type of genetic abnormality is RET mutation. RET is a receptor tyrosine kinase. So as we said, Hirschsprung disease is due to failure of the ganglion cells to migrate to the wall of the colon. So as a result, there will be absence of ganglion cells within the submucosa and muscular layers of the affected segment. So in order to diagnose Hirschsprung disease, you need histologic confirmation that the ganglion cells are absent within the submucosa and muscular layers. The rectum is always affected in Hirschsprung disease, but the length of the additional involved segments proximally varies widely between different patients. As a result of the absence of ganglion cells, coordinated peristaltic contractions do not occur, so functional obstruction results. And this functional obstruction results in dilation of the segments proximal to the affected segment. So the aganglionic segment will be narrowed. However, the normally innervated proximal colon undergoes progressive dilation as a result of the distal obstruction. Patients present with failure to pass meconium in the immediate postnatal period, and obstruction or constipation follows. In this picture, we can see the affected aganglionic segment, which lacks the ganglion cells, and it appears collapsed. Proximal to this affected segment, here we have the normally innervated, more proximal colon, and it is dilated as a result of the distal obstruction. This is a picture of the ganglion cells, and they are normally present within the submucosa and muscularis propria of the normal colon, as we see here in this picture. In the picture on the right, we can see here a full thickness section from a resection specimen of a colon, and there is absence of ganglion cells within the submucosal plexus, also known as Meissner plexus, and the absence of ganglion cells within the myenteric plexus or Auerbach plexus. So this patient has Hirschsprung disease. Now we will talk about the different causes of intestinal obstruction. We will focus on adhesions, intussusception, volvulus, and hernias. To note, there are other causes of intestinal obstruction, such as tumors and strictures. Strictures can occur in Crohn's disease, as we will discuss later in this lecture. Adhesions are fibrous bands that can occur between bowel segments, the abdominal wall, or operative sites. They typically develop following surgical procedures, infection, or endometriosis. They are a very frequent cause of small bowel obstruction. In this picture, we can see a band-like adhesion between loops of the small intestine. Intussusception is another cause of intestinal obstruction. In fact, it is the most common cause of intestinal obstruction in children younger than 2 years of age. In intussusception, one segment of the intestine telescopes into the distal segment, and it commonly occurs at the ileocecal junction, causing intestinal obstruction. So intussusception commonly occurs in children, and Meckel diverticulum is a common cause of intussusception in children. Intussusception can also be due to idiopathic, where there is no underlying anatomic defect and the patient is otherwise healthy, which means that the exact cause of intussusception is unknown. In adults, intussusception is uncommon and is generally caused by a mass or tumor that serves as an initiating point of traction. In volvulus, a loop of intestine twists about its mesenteric point of attachment. This will lead to obstruction of the intestine and it will lead to obstruction of the blood supply of the intestine. So the patient will present with obstruction, intestinal obstruction, and infarction due to obstruction of the blood supply of the affected loop. It commonly occurs in the sigmoid colon and cecum, and it can occur in infants, as we previously discussed, where we discussed midgut volvulus that can occur as a result of malrotation of the midgut during fetal life. Hernias are a very frequent cause of intestinal obstruction worldwide. In Arabic, hernia refers to fta. Hernia refers to protrusion of a serosal-lined pouch of peritoneum through a defect or weakness in the abdominal wall. And the content of the hernia may vary. It can include fat, it can include small intestine, and this can be complicated with obstruction. There are different types of hernias. These include inguinal hernias, femoral hernias, umbilical hernias. Complications of hernias include incarceration and strangulation. Incarceration means that the hernia cannot be reduced back into the abdomen or pelvis. Strangulation means loss of blood flow to the herniated bowel segment, and this can result in ischemic injury and tissue necrosis. Now we move to diverticular diseases. A colonic diverticulum refers to outpouching of the colonic mucosa and submucosa through the muscularis propria. Unlike true diverticulum, such as Meckel diverticulum, which is a true diverticulum, colonic diverticula are false diverticula. They do not include all the layers of the colonic wall, so it only includes the mucosa and submucosa. They commonly occur in the sigmoid colon, and they are acquired. They are caused by elevated intraluminal pressure, which leads to the mucosal herniation through the anatomic weak points in the muscularis propria. A low fiber diet also contributes to the formation of diverticula. Complications of diverticular disease include obstruction, where the diverticulum can get obstructed, and obstruction can induce inflammation, leading to diverticulitis. Inflammation and increased pressure within an obstructed diverticulum can lead to perforation, and perforation can result in pericolonic abscesses, sinus tracts, and occasionally peritonitis. In this picture on the left, we can see a sigmoid colon, and here we have the mucosa, and we can see numerous diverticula. So the mucosal surface shows diverticular ostia. So these are where the mucosa invaginated downwards. Here we have in this picture on the right a cross section where we can see the diverticular that has invaginated, the mucosa and submucosa have invaginated downwards into the fat. Okay, so here is a cross section of a diverticulum. In this picture on the left, we can see over here the colonic mucosa, then we have the submucosa, muscularis propria, and adipose tissue. And here we can see that the colonic mucosa and submucosa have invaginated downwards through the muscularis propria. Here is the muscularis propria. So the mucosa has invaginated downwards through the muscularis propria into the adipose tissue. And here is a higher power view of the invagination. Now we will briefly discuss vascular disorders, including ischemic bowel disease, hemorrhoids, and angiodysplasia. Ischemic bowel disease refers to ischemic injury affecting the small intestine and/or the colon. The majority of the gastrointestinal tract is supplied by the celiac artery, superior mesenteric artery, and the inferior mesenteric artery. And in spite of this extensive network of collateral arteries, there are watershed areas between the major arteries that are vulnerable to hypoperfusion. Watershed zones refer to intestinal segments at the end of their respective arterial supplies that are particularly susceptible to ischemia. And these include the splenic flexure, where the superior and inferior mesenteric arterial circulations terminate, and to a lesser extent, the sigmoid colon and rectum, where in the inferior mesenteric, pudendal, and iliac arterial circulations end. The damage resulting from ischemic injury can vary. It can range from mucosal infarction only, so the infarction is limited to the mucosa only, or it can be a mural infarction involving the mucosa and submucosa, or in the most severe cases, it can be a transmural infarction involving all three colonic layers. Ischemic bowel disease can manifest as an acute transient disorder that is completely reversible on re-establishment of blood flow, or it can manifest as an acute, severe, and irreversible form of injury, or it can manifest as a chronic recurrent disorder. The major variables that determine the severity of ischemic bowel disease are the severity of the vascular compromise, the time frame during which it develops, and the vessels affected. Ischemic damage occurs as a result of hypoxic injury and reperfusion injury. Hypoxic injury occurs at the onset of the vascular compromise. Reperfusion injury occurs when there is restoration of the blood supply, and the greatest damage occurs during this phase. Reperfusion of the bowel is required to recover from an episode of ischemia. However, the restoration of the flow of oxygenated blood has its own consequences because it results in the generation of oxygen-free radicals, and these oxygen-free radicals cause structural and functional damage to the epithelial cells, resulting in reperfusion injury. Causes of ischemic bowel disease include arterial thrombosis, and the most important risk factor for thrombosis is severe atherosclerosis. Another cause is embolism. Emboli most commonly originate from aortic atheromas or cardiac mural thrombi. In a large majority of cases, acute obstruction is caused by thrombosis or embolism. Other causes of ischemic bowel disease include mesenteric venous thrombosis, and it is an uncommon cause and can result from inherited or acquired hypercoagulable states. Intestinal hypoperfusion can also occur in the absence of vascular obstruction, such as in the setting of cardiac failure, shock, dehydration, or use of vasoconstrictive drugs. So the four main causes of mesenteric insufficiency are embolism, arterial thrombosis, non-occlusive or low-flow ischemia, and mesenteric vein thrombosis. In the picture on the left, we can see a segment of the jejunum that has undergone infarction as a result of ischemic bowel disease. We can see that the serosa is dusky colored and is hemorrhagic as a result of the infarction. In the picture on the right, we can see here a microscopic image of the colon, and we can see here that the mucosa is necrotic. It is dead, as opposed here to more viable areas in the mucosa. Now, a few words about necrotizing enterocolitis. Necrotizing enterocolitis occurs in premature infants or those of low birth weight, and it is the most common acquired gastrointestinal emergency of neonates. And ischemic injury is thought to contribute to the pathogenesis. It presents when oral feeding is initiated, and it affects the terminal ileum and ascending colon. It is an acute disorder of the small and large intestines that can result in transmural necrosis. Hemorrhoids refer to variceal dilatation of the anal and perianal venous plexuses. The most frequent cause is constipation because of straining at defecation, which results in hemorrhoids. Another cause of hemorrhoids is pregnancy because of the venous stasis that results secondary to the gravid uterus in the pelvis. Hemorrhoids can also occur in patients with liver cirrhosis due to portal hypertension that results. This is a microscopic image of hemorrhoids where we can see multiple submucosal, dilated, and congested thick-walled blood vessels. Angiodysplasia refers to the presence of blood vessels within the mucosa and submucosa that are dilated and thin-walled. They are malformed vessels, and the exact pathogenesis behind angiodysplasia is unknown. Angiodysplasia commonly occurs in the right colon and in the elderly. Now we will discuss celiac disease, which is a malabsorptive disorder of the small intestine. Celiac disease is also referred to as celiac sprue or gluten-sensitive enteropathy. It is an autoimmune disease that results in damage to the small intestinal mucosa. The small intestine is the site where absorption occurs, so damage to the small intestinal mucosa leads to malabsorption of nutrients. And celiac disease is triggered by ingestion of gluten-containing foods, such as wheat, rye, barley, in genetically predisposed individuals. It is strongly associated with HLA-DQ2 and DQ8. However, other genetic factors also play a role, such as polymorphisms of genes involved in immune regulation and epithelial function. This is a slide to illustrate the pathogenesis of celiac disease. You do not have to go into the specific details. I just want you to get an overall idea of the pathogenesis of celiac disease. So gluten is digested by enzymes into amino acids and peptides, including the alpha-gliadin peptide. The alpha-gliadin peptide is then transported into the lamina propria, where it will be deamidated by tissue transglutaminase. Then the deamidated gliadin peptide will interact with HLA-DQ2 or DQ8 on antigen-presenting cells. And these antigen-presenting cells will activate the CD4 positive T cells to produce cytokines that will activate the immune system and result in destruction of the small intestinal mucosa. Patients with celiac disease often have autoantibodies in their blood that can be tested for. These include IgA antibodies against tissue transglutaminase, IgA anti-endomysial antibodies, and anti-deamidated gliadin peptide antibodies. Patients with celiac disease can be asymptomatic or they can be symptomatic, and symptoms are related to malabsorption, and these include chronic diarrhea, bloating, chronic fatigue, anemia due to chronic iron and vitamin malabsorption, aphthous stomatitis, and dermatitis herpetiformis. Dermatitis herpetiformis is a characteristic itchy, blistering skin lesion that can be present in as many as 10% of patients with celiac disease. Patients with celiac disease are at an increased risk of developing a certain type of T-cell lymphoma called enteropathy-associated T-cell lymphoma. Treatment of celiac disease is very simple. It's just gluten-free diet. Adherence to a gluten-free diet results in resolution of symptoms. A biopsy is needed in order to diagnose celiac disease, and the preferred site to biopsy is the duodenum or proximal jejunum, because these sites are most likely to show the histopathologic changes of celiac disease. Microscopically, biopsy specimens from patients with celiac disease show increased intraepithelial lymphocytes. So, within the epithelium, there will be increased lymphocytes. Also, there will be villus atrophy. The villi increase the surface area for absorption, as you know. So, if there is blunting of villi, malabsorption will result, and crypt hyperplasia is another microscopic finding. However, these microscopic findings of intraepithelial lymphocytosis and villus atrophy are not entirely specific for celiac disease, and they can be seen in other diseases such as in viral enteritis. Therefore, the combination of histology, serology, and the clinical picture is needed to diagnose celiac disease. In the picture on the left, we can see a section from the normal duodenum. We can see that the villi are tall and slender, and there is no increase in intraepithelial lymphocytes. However, in the picture on the right, we can see that it's from a patient with celiac disease, and we can see by comparing and contrasting that the villi are blunted. They are not tall anymore. They are barely visible. And they are rich in lymphocytes. So there is increase in lymphocytes within the epithelium. Also, there is increase in inflammatory cells within the lamina propria. These are all findings of celiac disease. Now we will briefly discuss infectious enterocolitis. Infectious enterocolitis can result from bacterial, viral, or parasitic infection. This table is just to illustrate that there are different types of bacteria that can cause infectious enterocolitis. This is not a bacteriology lecture, but I just want you to know that different bacteria have different pathogenic mechanisms and can cause different symptoms. For example, Vibrio cholera can cause severe watery diarrhea through the production of cholera toxin. Other bacteria invade the intestinal mucosa and cause bloody diarrhea. Some adhere to the surface of enterocytes. Some bacteria have more than one mechanism, and the result can be watery diarrhea, bloody diarrhea, abdominal pain, fever, and malabsorption. Whipple disease is a rare disease caused by the gram-positive bacteria Trophilema whippeli. It is a systemic disease, which means that it affects multiple organ systems. The clinical presentation is usually a triad of malabsorptive diarrhea, weight loss, and arthralgia. Extraintestinal symptoms may precede the malabsorption, and they include arthritis, arthralgia, fever, lymphadenopathy, neurologic, cardiac, or pulmonary disease. In Whipple disease, there will be accumulation of bacteria-laden macrophages, and these accumulate within the lamina propria of the small intestine and within mesenteric lymph nodes, causing lymphatic obstruction. So the malabsorptive diarrhea of Whipple disease is due to impaired lymph drainage. Microscopically, you would see when you have a biopsy from this small intestine in a patient with Whipple disease, there will be accumulation of foamy macrophages within the lamina propria. And these macrophages contain granules that represent partially digested bacteria within lysosomes. And these granules are positive for PAS or periodic acid shift. These are microscopic images from a patient with Whipple disease, and this is from the small intestine. Here is a low power view, and here is the higher power view. We can see within the lamina propria there are macrophages, and these macrophages are foamy. So there is accumulation of macrophages within the lamina propria. These foamy macrophages stain dark pink or red with the PAS stain, so they are PAS positive. Pseudomembranous colitis is also referred to as antibiotic-associated colitis. It is a type of acute colitis that is caused by bacteria Clostridium difficile or C. difficile. And this type of colitis usually occurs after the use of broad-spectrum antibiotics. These broad-spectrum antibiotics cause disruption of the normal colonic microbiota, and this will allow Clostridium difficile to overgrow. And this bacteria releases toxins, and these toxins cause the development of purulent pseudomembranes, hence the name pseudomembranous colitis. These pseudomembranes are made up of an adherent layer of inflammatory cells and debris that adhere to the injured colonic mucosa. In pseudomembranous colitis, multiple pseudomembranes are seen on the colonic mucosa, as we can see here in these two pictures. And these pseudomembranes are discrete plaques, and they are composed of fibrinopurulent necrotic debris that adhere to the damaged colonic mucosa. This is an example of pseudomembranous colitis, where we can see here we have the pseudomembrane that is composed of fibrinopurulent necrotic debris, and the pseudomembrane is adherent to the colonic mucosa. And here we can see the neutrophils emanating from the damaged crypt like a volcanic eruption. The most common causes of viral gastroenteritis worldwide include norovirus, rotavirus, and adenovirus. Norovirus is responsible for about half of all the gastroenteritis outbreaks worldwide. Rotavirus is a significant cause of diarrheal death worldwide. It usually infects children between 6 and 24 months of age. They are the most vulnerable to rotavirus. Parasites are a much less common cause of infectious enterocolitis. Here in this slide, we can see a list of some parasitic infections that can cause infectious enterocolitis. Entamoeba histolytica have a foamy cytoplasm, so they resemble macrophages over the microscope. However, the presence of ingested red blood cells within them is a clue that this is Entamoeba histolytica. Entamoeba histolytica, they cause ulcers, and these ulcers may undermine the adjacent mucosa to produce classic flask-shaped lesions. Giardia is another cause of parasitic enterocolitis. Secretory IgA is important to clear the Giardia infection. This is why patients who are immunosuppressed or have A-gamma globulinemia are severely affected with Giardia. Also, patients with IgA deficiency have increased susceptibility to develop giardiasis. Giardia trophozoites can be seen in duodenal biopsies. They have a characteristic pear-shaped appearance, and you can see here two equally sized nuclei. These are pictures from a duodenal biopsy, and here we can see the Giardia trophozoites at the luminal surface. And we can see that they have a characteristic pear-shaped appearance and two nuclei. Patients with immune deficiency, such as AIDS patients, are at increased risk of developing opportunistic intestinal infections. These infections include infection with Giardia, Cryptosporidium, Microsporidium, CMV, herpes virus, and Mycobacterium avium intracellular. In this slide, we can see pictures of Cryptosporidium. Cryptosporidium appears as a basophilic, which means dark, spherical body that is present on the surface of enterocyte. So here we can see the Cryptosporidium organisms that are present on the surface. And here also we can see them. So they appear as blue beads. This slide illustrates cytomegalovirus inclusions. So cytomegalovirus here has infected the endothelial cells. So these cells will be large, they will be cytomegalic, and there will be intranuclear basophilic inclusion surrounded by a clear halo, creating an owl eye appearance. In addition, there will be multiple, much smaller cytoplasmic inclusions. We will now discuss inflammatory bowel disease, which includes Crohn's disease and ulcerative colitis. Inflammatory bowel disease is a chronic inflammatory disease due to inappropriate immune activation. It results from complex interactions between intestinal microbiota and host immunity in genetically predisposed individuals. The two disorders that comprise inflammatory bowel disease are Crohn's disease and ulcerative colitis. This slide illustrates the main differences between Crohn's disease and ulcerative colitis. So let's start. Crohn's disease may involve any area of the gastrointestinal tract, from the mouth to the anus, and the terminal ileum is usually involved. Ulcerative colitis, on the other hand, involves only the colon and the rectum. There is always rectal involvement. In Crohn's disease, there is transmural inflammation, which means that the inflammation extends all the way throughout the colonic wall, from the mucosa through the entire colonic wall. Whereas in ulcerative colitis, the inflammation is not transmural. It is limited to the mucosa and submucosa. In Crohn's disease, you see skip lesions. These skip lesions are very characteristic. We mean by skip lesions an area in the colon that is inflamed, and next to it, there is an area that is not inflamed. And then next to this area, there is another area that is inflamed. So you see normal areas in between inflammatory areas. Ulcerative colitis, on the other hand, you do not see skip lesions. The area of inflammation is continuous. It is not interspersed by normal mucosa. So there's continuous colonic involvement with inflammation beginning with the rectum. In Crohn's disease, so both in Crohn's disease and ulcerative colitis, you can see ulcers. In Crohn's disease, usually they are deeper. Crohn's disease, you can see granulomas in 35% of cases, whereas no granulomas are seen in ulcerative colitis. And these granulomas are usually non-caseating. In Crohn's disease, there is malignant potential only with colonic involvement. So there is increased risk of developing adenocarcinoma only if there is involvement of the colon with Crohn's disease. Whereas in ulcerative colitis, there is increased risk of developing colonic adenocarcinoma. Complications differ also. In Crohn's disease, there is increased risk of developing fissures, sinuses, fistula tracts, strictures, fat, and vitamin malabsorption. A sinus tract, we mean by a sinus tract, it's like a small channel in the body that usually extends from the cause of inflammation to the skin surface. A fistula is an abnormal connection between two body parts. A fissure is a tear. Usually it is seen in Crohn's disease in the anal mucosa. So patients with Crohn's disease may develop anal fissure. And these complications are because the transmural inflammation seen in Crohn's disease causes fistulas and strictures with time. And these complications are not seen in ulcerative colitis. However, in ulcerative colitis, there is increased risk of developing toxic megacolon. Extraintestinal manifestations can occur and they are common to both Crohn's disease and ulcerative colitis. And they include migratory polyarthritis, sacroiliitis, ankylosing spondylitis, uveitis, and skin lesions such as erythema nodosum and pyoderma gangrenosum. This slide nicely illustrates the differences in distribution between Crohn's disease and ulcerative colitis. So in Crohn's disease, there is always terminal ileal involvement, and as you can see, there are skip lesions or patchy distribution of Crohn's disease, area that is inflamed followed by a non-inflamed area, then an inflamed area. Whereas in ulcerative colitis, there is continuous colonic involvement, continuous inflammation, no skip lesions, and there is always rectal involvement. The earliest lesion of Crohn's disease is the aphthous ulcer, and this can progress and multiple lesions can coalesce to form elongated serpentine ulcers. Due to the patchy distribution of Crohn's disease, the presence of ulceration and adjacent to it normal mucosa can result in a cobblestone appearance of the mucosa. These are two pictures of a colon with Crohn's disease. We can see here in the picture on the left that there is extensive ulceration covered with hemorrhagic exudate. And these are islands over here of residual uninvolved mucosa. And these islands of uninvolved mucosa, they bulge from the surface and they create a pseudopolyp appearance and a cobblestone appearance. And here also in the picture on the right, we can see also a colon that has a cobblestone appearance. There is extensive ulceration and the residual mucosa, uninvolved mucosa, creates a cobblestone appearance. So the inflammation in Crohn's disease, as we said, is transmural, involving all the layers of the colonic wall. And the complications that arise include, as a result of this transmural inflammation, include fissures. And as we said, a fissure is a break in the tissue, usually occurring at the junction of the skin and mucous membrane. And in Crohn's disease, usually there are anal fissures. And fissures, they may extend deeply to become fistula tracts or can even cause perforation. Another complication is stricture. So the intestinal wall is thickened as a result of the transmural inflammation, resulting in intestinal stricture. So in this picture here, we can see an intestinal stricture, which is narrowing of the lumen, and it can occur in cases of long-standing Crohn's disease. Another complication of Crohn's disease is creeping fat. So when there is extensive transmural disease, the mesenteric adipose tissue frequently extends over the serosal surface, termed creeping fat. In the picture on the left, we can see a microscopic image of a colon with Crohn's disease. Here we have ulceration, and then we have colonic mucosa, and then ulceration. And we can see here in areas of ulceration, the mucosa is denuded and is replaced by fibrinopurulent exudate. And as if we look at the colonic wall, we can see there is transmural inflammation. The inflammation extends deeply throughout the mucosa, submucosa, and reaching the muscle also. Here is the muscle. And so these are features of Crohn's disease. And here the inflammatory infiltrate consists of acute and chronic inflammatory infiltrate. Another finding seen in Crohn's disease, but not always, but if you see it, it's very helpful. It is granuloma. A granuloma is a collection of epithelioid histiocytes. Here is a granuloma, here is another one, here is another one. And also you can see in addition within the granulomas multinucleated giant cells. This is a multinucleated giant cell. Here we have another one. So a granuloma is a helpful feature of seen in Crohn's disease. So as we said earlier, in ulcerative colitis, there is always rectal involvement and the inflammation extends proximally in a continuous fashion. And in severe cases, there may be inflammation of the entire colon, and this is termed pancolitis. The small intestine is usually normal. However, in severe cases of pancolitis, the inflammation may extend into the terminal ileum, and this is termed backwash ileitis. Islands of regenerating mucosa, they bulge into the lumen, and this can create a pseudopolyp appearance. Pseudopolyps are also seen in Crohn's disease, as we saw earlier. A complication of ulcerative colitis is toxic megacolon. It occurs uncommonly and in severe cases of ulcerative colitis that are associated with inflammation of the muscularis propria, and this will result in neuromuscular dysfunction, which can lead to severe colonic dilation and hence toxic megacolon. Toxic megacolon carries a significant risk of perforation. Another thing in ulcerative colitis is that 2.5 to 7.5% of patients with ulcerative colitis also have primary sclerosing cholangitis. This is a picture of a colectomy specimen from a patient with ulcerative colitis. Here you have the normal colonic mucosa, and here you can see there is the inflamed colonic mucosa. There is continuous inflammation. We can see that the mucosa is hyperemic, and there are numerous pseudopolyps. So in ulcerative colitis, there is usually inflammation in the mucosa and submucosa, and this inflammation consists of acute and chronic inflammatory cells. Crypt abscesses can be seen. Crypt abscesses refer to the presence of neutrophils within the glandular lumen. Crypt abscesses and acute and chronic inflammation are also seen in Crohn's disease. However, in ulcerative colitis, we do not see granulomas. One of the most feared long-term complications of ulcerative colitis and colonic Crohn's disease is the development of colorectal adenocarcinoma. And preceding adenocarcinoma, dysplasia will differ. And the risk of developing dysplasia and subsequent cancer is related to many factors. These factors include the duration of the disease. The longer the duration of the disease, the higher the risk of developing carcinoma. The extent of the disease. Patients with pancolitis are at greater risk than those with only left-sided disease. Also, Crohn's disease patients without colonic involvement are not at increased risk of developing dysplasia. And the nature of the inflammatory response. The greater frequency and severity of the active inflammation confers increased risk. So, in order to detect dysplasia before it develops into carcinoma, patients undergo surveillance colonoscopy, where they undergo colonoscopy in order to identify any dysplasia before it progresses into carcinoma. This concludes our presentation. In this presentation, we discuss the various non-neoplastic pathologies that affect the small and large intestines, and these include congenital disorders. We also talked about the causes behind intestinal obstruction. We went over diverticular disease, vascular disorders, and we talked about celiac disease, which is a malabsorptive disorder. It is an autoimmune disease. We went briefly to talk about infectious enterocolitis, and we ended with inflammatory bowel disease, which is an inflammatory condition. In the next lecture, we will discuss the neoplastic processes that occur in the small and large intestines. We will discuss the different polyps and the different tumors that occur over there.